All right, good afternoon, everyone. Thank you for joining us for this month's edition of Grand Rounds video lecture series. Is Suan in the chat? Suan, are you there? I would just like to wish Suan a happy birthday. All right, now that we've got that out of the way, we can get started. We have Dr. Joseph Masternick, who's a physician within our behavioral health department at Flint, our Flint location. And he's going to be giving us a presentation on substance use disorder update Vivitrol review. Did I pronounce that right?
Vivitrol.
Vivitrol. Okay. All right. Take it away, Dr. Masternick.
Well, thank you for inviting me back to speak. I enjoy these. The Vivitrol review shouldn't take too long. I thought today I would just start with a few thoughts about where substance use disorder is going. And we're going to focus mostly on opioid use disorder and alcohol use disorder. Just to review some current thinking and talk about these pharmaceutical tools available to the provider. And just one consideration that treating alcohol use disorder, opioid use disorder, consider that it isn't all quite about physiology. And it's a learned errant pathological behavior that is not so much about physiology. And we'll get into what I'm referring to as we proceed. So I know our talk is on Vivitrol, but let's just start with where we are currently. Last year, we had about 106,000 inadvertent, unintentional drug overdoses. And in Michigan, we had nearly 3,000, and we're in the top 10 states of that. And most of them were all related to fentanyl. As you know, we're still in this crisis. And I think earlier in the year, we had 6 West Point cadets overcome when they thought they were taking Norco. 2 died from overdose, is what I recall, when it was fentanyl pills. So fenta pills are being substituted everywhere. Vaping put in, the marijuana put in, everything. And people come in every day and they say, I am paying for heroin, but I'm getting fentanyl. And I know that because fentanyl hits the individual in a different way than heroin does. So we still see this blue line here that represents mostly the fentanyl impact in our opioid crisis today. Now, we are doing a much better job of decreasing and changing our prescribing patterns, and we're down a good measure. We are down to about the 2001 level, which is about the onset of the whole mess. Actually, it was in the late 90s when it all started to unfold and skyrocket. So I just included a little graph on the left, morphine mill equivalents, and where that's going over the last 2 decades, and where our specialties are listed. You could see oncology down 44%, which I'm not too sure. We deal with non-cancer pain. The oncologists deal with cancer-related pain. I'm not too sure why that is down substantially, but people that are in pain with cancer, it's really a different ballgame. So, but you could see surgery, dentistry, and primary care certainly down a good measure in their opioid prescribing patterns. I take care of a number of dentists, and what used to be a prescription for 40 or 50 Norco after a procedure is now usually 12. And, you know, as far as treatment goes, I mean, we're looking at harm reduction is the big deal. And we need to use everything we can to provide harm reduction. And I think the more trained the provider becomes, the patient is dysfunctional. The patient is usually 80% have concomitant mental illness, and you don't want to put a lot of hurdles in front of them, not a lot of barriers to obstruct their progress in the evolution of their recovery. And you have to be careful. You have to pick your battles. So if they have alcohol in their urine, their point of service drug screen or their toxicology screen picked up ethyl glucuronide or ethyl sulfate, you just need to explain it and understand it. And you don't throw people out of programs because they have THC in their urine when they didn't have that before. You just need to work with them, and you use these drug screens results as another tool to help them understand what they're doing. So we really don't try to pick small battles. We have to keep in mind that if they're here for, let's say, heroin addiction, if you say too much, if you lean on them too much, if your pride gets in the way, you just don't want them to not show up next time because they're back on the street using and rolling the dice on their life. So you have to be careful. So as far as pain patients go, chronic pain patients go, most of them are fine, and they understand. Yes, we have a few, about 10% get in trouble, and we see misuse and abuse, but not many develop frank dependency issues. Those that do, they need to be addressed. And if you have pain medicine and they're using it for a sinus headache, or they bang their elbow, they need to know that that's not appropriate to take these medicines for these items. Oh, okay, so we'll switch here. So if we could just go through a little background history, we have two opioid antagonists that we use. You all know naloxone or Narcan, which is used as an antidote for managing overdose of opioids, versus naltrexone, which is used to manage alcohol use disorder and opioid use disorder by reducing cravings and the risk of relapse by blocking pleasure center neurotransmitters namely beta endorphin. When the alcohol is consumed, runner's high, when you exercise, eating, sex, beta endorphin is released. Naltrexone was approved in 1994 for alcohol addiction. And by blocking the endogenous opioid release, the beta endorphin, it prevents the drinkers from feeling pleasure when they drink. And to explain alcohol addiction, there are two parts to the equation. One is drinking more is an attempt to maintain comfortable GABA levels, which is the brain's primary calming neurotransmitter, let's say. And to the profound sense of pleasure and euphoria and reward that our brain associates with drinking and or drug using. And for people engaged in drinking, let's say, nothing releases endorphins as intensely as large quantities of alcohol. And from an evolutionary perspective, we need to remember things in our environment that give us pleasure so that we can instinctually seek these out for future enjoyment. It's part of life. However, with addictive patients, the brain's attempt to automate goal seeking can end up threatening life survival. So the progression of drinking and drug using can therefore be seen as a learned behavior. And let's talk about how some individuals, and partly for genetic reasons, they get so much reinforcement each time they drink that the behavior becomes too strong. And to define reinforcement, actually, I'm probably not that far yet, but that's okay. To define reinforcement, we just start with this endorphin release and activation of our reward pathways. And the brain learns basically how to strengthen behavior from the reinforcement. So last night's drinking was a great time, and that buzz felt so good, and all my troubles disappeared. And I was the life of the party, and all the bells and whistles went off. So these all create positive memory traces that are filed away in that hippocampus, and it's associated with enjoyment. Just like when you were 10 years old and you got a shiny new red bike and a chocolate cake, and everybody hugged you and gave you kisses, and you got presents from your aunts and uncles. But when the euphoria is blocked by medication, this medication, naltrexone, and the only thing drinking really produces at that point is falling down, banging into doorways, and slurred words, as if you just acquired a neurological disease. And there is no euphoria, there is no high, there is no pleasure derived because all this was blocked. Then the brain begins to rethink the whole equation. Like, why did I do that? Why did I do that behavior? I didn't get much out of it, and I was basically uncomfortable. So reinforcement curtails, and the extinction mechanism is activated, which will lead to less euphoria and hopefully less drinking, drug using, and less cravings later. So by all that, we end up with involuntary impulses are reduced. through the introduction of a stimulus without a reward. And I think it's just 2, 3. Okay, so when you look at addiction, you look at substance use disorder, it's basically a tug of war between the cerebral cortex, the decision-making, reasoning area of the brain, and the primitive reward-seeking areas of the ventral tegmentum and the nucleus accumbens. And this circuitry is part of the limbic system. And when substance use disorder hijacks the reward circuitry, the primitive side will win most of the battles. And these drugs and alcohol begin to shape and drive behavior. Life's responsibilities often get set aside. The day's main effort later will become just acquiring and using these drugs. And this pathological behavior basically it'll result in dysfunction, life dysfunction. And we end up with lost opportunities in our lives. And these lost opportunities are more profound the earlier, like an adolescent brain is very impressionable, and disease is more severe the earlier these problems arise. And we start with lost educational opportunities. The grades become poor, and when your grades are poor, then usually we end up with lesser jobs. You don't realize potential, and when we have less educational opportunities, that will translate into less financial opportunities. And then that seems to affect relationship opportunities. We want to attract a mate, and a mate is looking for certain qualities, and when they aren't there because of this other pathological behavior, then unfavorable things result. And then that individual is labeled as an alcoholic or a drug addict, and then what happens is usually disillusionment with life, and the more work you miss, and the more kids' ball games you miss, and the more you departicipate from spousal activities and your world, as the abyss of addiction grows, the addictive individual has less choice, and his best defense mechanism is to really just try to forget about it by spending most of the rest of the life just with the only friend he has, which is his drug of choice. And we know that left untreated, this chronic brain disease of the reward pathways, just like other chronic diseases, diabetes, hypertension, and asthma, let's say, are usually fatal if left unmanaged. Let's go. So counseling emphasizes the executive function control over the midbrain's selfish reward seeking areas. Through recovery learning, using any and all tools, we caregivers have available to us, including psychosocial support and using principles of AA and NA. The substance use disorder patients hopefully will get to a point where they can look in the mirror in the morning and say, I did good yesterday, and I can do it again today. In other words, they can promise their behavior to themselves for the day. If you had a bear walk by our room full of people and he smelled honey and there was honey here, he would have no problem killing us all and eating all the honey and go home, and Mama Bear would say, well, how was your day, dear? And he would say, it was just great. I found some honey, ate it, and I brought you some too, dear. Us, on the other hand, us humans, and being mammals, we have one unique feature above all other mammals, and that is our brains can calculate the outcome of current behavior. In other words, if we were short on cash and we decided we needed some cash, so we would go to the ATM and take a hatchet to it and get $3,000, wouldn't that be nice? We would know that someone would likely come visit us within 4 hours at our house and take us away. So the idea with recovery training is, if you're going to be bad and slip, relapse, whatever, then you know the outcome. You'll be a less valued employee. You create problems in all your relationships. So as far as Vivitrol goes, it's approved for patients who are abstinent from alcohol, usually for about 4 days, and opioids 7 to 14 days, who are engaged in psychosocial support. Usually you don't have to do a naloxone challenge. It's not necessary. However, if you're not sure about the situation, if the patient is unreliable or has some other issues, you may want to do it. And you could give 0.2 to 0.8 milligrams IM or IV. It's a small dose. It's small enough that if you do precipitate some withdrawal symptoms, they're usually gone in 30 to 60 minutes. So it'll give you a better idea, but I don't ever really have a need to do that in an ambulatory setting. And I tell people before we give anything with a blocker, even Suboxone, even buprenorphine that actually has a higher affinity for the mu receptor, and it argues with any other opioid that's in there, that, you know, if you feel anything and you start with a very small dose, just wait another 4 hours, drink some juice, walk around, and it's okay to be miserable for a few hours. You've been there before many times. So as far as the Vivitrol goes, we like to let it set out for about an hour, come to room temperature before we give the IM injection, the monthly IM injection. And what we're after is to reduce cravings, alcohol reinforcing properties, and the whole experience of intoxication is diminished. And also to reduce the chances of continued drinking or binging following a slip. And I'll give you data on that shortly. Let's see, let's go to, okay, so it blocks the mu receptor. This is pretty straightforward stuff. And And I'll talk about some side effects and safety issues. So, all right. This results in some pretty good changes in behavior. We see IM Vivitrol impacting relapse quite a bit, about 38% lower incidence of relapse. And, you know, the difference between this and antabuse is if you drink anything on antabuse, if we're talking about alcohol, then you're going to be sick. You're going to be afraid you're going to die, and maybe afraid you won't die because you feel so bad. So there's no contraindication to having a drink, but you're going to get less out of it. And the idea is that you will question that and you will think that this is a silly behavior. And that's how we get the good result. So we study different things in terms of how to assess outcomes. And we look at whether there's decreased total alcohol consumption during the treatment. We look at the time to the next relapse, the less percentage of drinking days, the total number of drinks you have in your drinking days, more days of abstinence. And for those that have abnormalities of liver function, AST, GGTP, how do those perform in treatment versus no treatment? So I will just talk a little bit about Revia, which is the oral form, REVIA, the oral form of naltrexone. Comes in a 50 milligram dose. It's the only dose they make. And some don't want a monthly shot in their hind ends. And they would rather use there's a famous method that was invented called the Sinclair Method that works really pretty well. You simply just take and you start with a low dose to avoid startup side effects like typical nausea, dizziness, some headaches, fatigue. You start low, 25 milligrams, half a pill, about an hour before you think you're going to drink, and then it blocks the endorphin release. And if you want to know more about the Sinclair Method, you could Google it or let me know. I can tell you all about it. And I do use it. So when we look at 6-month data for IM Vivitrol versus placebo, we see one study said there was a 25% fewer heavy drinking days, and heavy drinking days were defined by, in males, 5 or more drinks in a day, women 4 or more drinks in a day. And IM Vivitrol versus placebo, the retention rate was better than the oral. About half in 6 months are retained in treatment, and only about 20% in the oral version. When they study these things, they don't even have 1-year data. The idea is that whatever you need to do it now when they have an interest in making their lives better. So after that 6-month window, usually they're on their way with their mental tools that they've learned in the recovery process through psychosocial support, their peer meetings, life coaches. I use digital cognitive behavioral therapy programs that I give them in their cell phones. that they carry around to manage the problems of their day. And it's all helpful. And, you know, we have other medications too. And so I looked at my ASAM textbook, American Society of Addiction Medicine, my big textbook that we all buy. And there was one study that was also mentioned in the Vivitrol literature that I would like to go over with you. So IM Vivitrol versus placebo. This was O'Malley in 2007, Journal of Clinical Psychopharmacology, based on self-reported outcomes, showed, and these are categories that are studied, greater median time to the first drink once you're in treatment. And it was a 3.5-fold better outcome, 41 days to 12 days. And a greater median time to the first heavy drinking day, remember the 5 and the 4, and that was a 9-fold improvement, 180 days versus 20 days. And a lower number of drinking days per month, which was a 10-fold difference. And that was 0.7 to 7.2 days. And finally, a lower median heavy drinking days per month, which was a 15-fold improvement, 0.2 to 2.9. And let's advance to this next slide here. Now, Vivitrol for opioids versus placebo at 6 months, we see pretty good results. 36% complete abstinence was maintained in the Vivitrol treatment group. And this is measured by weekly urine drug screens and no self-reported use. Also, we see about 17 times likely to relapse to physical dependence again from some slip or mishap. So now for more 6-month data for alcohol, this seemed to work better for the group that was able to not drink for the first week, because you should be abstinent at least 4 days for alcohol, just to help you with any startup side effects. Also, there are some injection site issues, bumps and some pain. They really were studied, and they were found not to be a causative issue of discontinuing the program, but they can be problematic. This is why we alternate left and right gluteal areas monthly. And it's rare, I've never seen any, but it is possible to have some tissue necrosis. But what this treats is craving scores are down 55%. And it's pretty good if this, after about a month, when it reaches a steady state, this is when it really begins to do its job. And what I wanted to talk about is that it's expensive. It's up to $900 a month, but Alkermes' copay savings program is really phenomenal, and it covers up to $500 copay. And those eligible patients 91% of the patients are eligible for this program. Or rather, 91% of the eligible patients had zero copay. So I think it's a pretty good deal. And either orally with the Revia or the Vivitrol, if we know about these extra tools that will change the reinforcement levels, then this is called pharmacological extinction of a pathological behavior. And we need more tools like this. These are safe to use. You have to be aware of whether they have severe liver disease. So it's a good idea. And I like to check liver function just before we use this. So I think I am pretty good with what I've said. Does anyone have any questions? But if anyone has any question about how to use oral Revia for alcohol use disorder, let me know. I'm happy to walk you through it. And if you have any questions about the Vivitrol, I don't own any stock in any of it, so I'm just a guy in the trenches trying to do good for these poor souls, and we need to help them along, because if you help these folks, you're helping their families, you're helping their employer, and you're allowing them to become the man or woman they intended to become. And God bless us for helping them do that. Thank you.
All right. Thank you, guys. If anybody has any questions, I've given you the ability to unmute yourself, so feel free to unmute yourself and ask any questions. Or if anybody is too afraid, you can write it in the chat and I'll ask it. Dominique, want to thank you, Dr. Masternick, for your presentation. And if nobody has any questions, we'll end this this meeting. All right. Thank you, guys. Have a good afternoon.
Thank you.